Terriac, and I'm a member of the Concord Hospital Trust team, and I'm also Pamela Puleo's assistant, which I'm very honored to be. On behalf of the entire Trust team, I want to welcome you to today's What's Up Doc program that launches our 2020 season. And it's so hard to kind of think in terms of 2020, that sounds so strange. But before I introduce our wonderful speaker, I want to just mention the items that have been placed on your table, informational items for you, and one of which is every month I'll be doing a little handout on the speaker of the day, and also at the end it will talk about the next month's program so that you can be reminded about that. We did mail out What's Up Doc postcards to everyone. I have heard from some people, they went out over the holidays that you didn't get one, so I put a couple on each table, so if you didn't get one, it's a great thing to just take home and stick on your fridge or whatever to remind you about the programs. The Trust team is very excited about our year of all of our very special events. And we have a save the date card that I would also encourage you to take a look at and be mindful of the dates of these special events. Kicking off our special event season is our Crafts, Drafts, and Barrels event, which is scheduled for Friday, March 20th. It will be held again at the McAuliffe Shepherd Discovery Center here in Concord. Very popular event. We hope you can join us. So there's a little postcard with the astronaut there about that particular event. We also mailed out over the holiday season your Trust newsletter. So, and again, I've heard from some people that they did not get a copy. So out on that table where the name tags were, we've placed some copies of the Trust newsletter. So if you did not get a copy, by all means, please pick one up. It is full of great stories, great information about what the Trust is doing, and all the different ways that your support, your very valuable support, goes to support Concord Hospital and our programs and services to meet the needs of the people in the communities that we serve. And let's see here. And also, we're very excited about a new development with the Concord Monitor. And thanks to the efforts of Jen Dearborn, our web manager, Jen prepares ahead of time 5 questions for the What's Up Doc presenter to respond to. And then after the program, and as you may know, many of you are here all the time, Jen is recording the What's Up Doc sessions, and they are available on the Concord Hospital YouTube channel. But also this past, or not the past Sunday, but January 5th, last month's What's Up Doc speaker, Dr. Christopher Four, who talked about the Concord Hospital transfer station, the article appeared in the Concord Monitor. So this is a great way for the session here that we do, What's Up Doc, can be repurposed, and that members of the Concord community can also learn about things that happen, or information that's passed on through our What's Up Doc programs. And then finally,
if I could just interject, certainly, if you ever talk to anybody at the Concord Monitor, please say thank you, because they are providing that service for us free. And so they're sharing that information with the community free, and that is, we're really very grateful. And of course, Joe Farrelly is probably the one who's here that goaded them into it by telling them that they should be at these sessions. So I think this is their compromise.
no problem, terrific. And then finally, there's a half piece of paper. I'm always interested in getting feedback on our sessions, the things that you like, and anything that you might want to offer that would help enhance your experience here, and certainly thoughts about future topics and subject matter that you'd like to hear about through our What's Up Doc series. At this time, I am very excited to present our What's Up Doc speaker. Dr. Matthew Gibb is our Concord Hospital's first Chief Clinical Officer. Dr. Gibb joined Concord Hospital in September of 2019, coming from Urbana, Illinois, where he was a leader in the Carle Health System for more than 20 years. Dr. Gibb has extensive experience as a practicing physician and in leading physicians and mentoring future leaders, establishing a collaborative working environment, and forming a strong professional relationships based on trust and open communication. Dr. Gibb is actually a former United States Navy flight surgeon, trained in internal medicine and cardiology. Dr. Gibb will also spend a portion of his time here serving as a practicing physician. As Chief Clinical Officer, Dr. Gibb will be responsible for strategic priorities involving the growth of Concord Hospital's healthcare system, improvements in clinical processes, and new programs to improve our patient care. Please join me in welcoming Dr. Matthew Gibb.
Thank you so much for having me. 3 months in, and this has been quite a good experience. I'm thrilled to be here, so wanted to start with that. I thought I would maybe give a little bit more about my background so you kind of know who Matt Gibb is and, you know, how did I end up in Concord. So we'll start not too far back, but enough. I grew up in Worcester, so I'm a New England person. My family moved there in the early 60s, and I went to Dartmouth undergrad, so I have a lot of ties to the New England area, and in particular New Hampshire. And then from Dartmouth, I went to medical school in St. Louis at St. Louis University, and I got into the Navy because I had a scholarship for medical school, so that was a great opportunity to get the medical education and also manage the cost of it. And I ended up staying in the Navy for 12 years on active duty. So I did my internship in Portsmouth, Virginia, and then was fortunate to get into a program that allowed me to both train as a flight surgeon and also learn to fly. So I ended up in the aviation community of the Navy, both as a pilot and a flight surgeon for about 4 years, and then went to San Diego where I did my fellowship or residency in medicine, fellowship in cardiology, and then I'm an interventional cardiologist. I did that part at UCSD in San Diego. And then I went to the Bay Area and was at the Navy Hospital there, now closed, but it was called Oak Knoll, and I spent 3 years there before getting out. And when I got out, it was really about the career projection in the Navy for me, which would have required me to not do clinical work for at least 3 years in order to continue being able to be promoted. It's you know, it just was not at a point in my career where that was appealing. So I went to what was then called the Carle Clinic Association in Urbana, Illinois, which was a large medical group, multi-specialty group with quite a few ties to the Mayo Clinic model. So it was started in the 1930s by Mayo Clinic physicians, and really was in the Midwest area one of the leaders of what does a multi-specialty group look like, and was fortunate enough to both have a clinical career and a leadership career, and you know, I won't go into all of that, but I stayed for 24 years, and the opportunity came for a number of reasons for me to come back to New England, and so as I started to look for what that could look like, I was offered the opportunity to explore Concord Hospital, and it lined up with everything I've been doing and all my interests around the things I could do or contribute to, which we'll talk a little bit about. So as Bob Stegmeyer and I talked for a while about how that might line up, I think we both felt more and more like we could we could probably have a good team around many of the things that are coming in front of us in the Concord Hospital system. So that is me. On a personal note, my wife is a nurse practitioner. We moved up in the Sunapee area, so I'm really enjoying that. Right now, the home includes our 4 elderly cats and a new golden retriever. So we're living the dream of the puppy right now. And I found there's a lot of dog people here, so you guys understand what I'm talking about. So that's that. And I wanted to really treat this as more of a fireside chat and a dialogue. I hope you guys will ask tough questions, because that's what I'd like to talk about, is your impressions, and I'll throw out some thoughts and stop after a little bit and we can get into some dialogue, because I need to know what your impressions are too. I'm new to the system and new to Concord, and I really am just learning about all the things that have a context for how we grow and how Concord Hospital evolves. So let me start with a couple of themes. The first thing I think is critically important is to talk about access. So one thing that we have in front of us as a challenge at Concord Hospital is access to care, and I'll define that a little bit. That is in the primary care community, where we have had a limited ability to add new patients to the system for a couple of years, and in the inpatient environment, we have had some glass ceilings about how we transfer people into the facility and add access for more of that to happen. So that's one of my biggest projects that we're starting with. And in the context of that, I'd link it to quality, because we traditionally think about quality in healthcare as, how do we do if I see you as a patient and we're dealing with a problem, and did we do a good job? Did we get a good outcome? We measure that a lot in healthcare and measure it pretty well. What we don't necessarily measure is, what does it mean to have a mission to serve the community, and how does limited access or looking at the patients that are our patients that we don't see all the time face to face in the office, how are they doing? And population health is a emerging concept in healthcare that is oriented around looking at that bigger picture of having all of us, both as practitioners and as leaders, understand that if we can't really see you, we can't provide the quality, because we're not having that interaction. But it is as important, because if you're in our region, we hope you'll be one of our patients in the population, and we would like to understand how that's evolving. So another piece of my work with Betsy Reinhardt is looking at, how does population health evolve in our system, and how do we begin thinking about the people that either we're not able to see or that we don't see regularly but still have disease processes like diabetes and high blood pressure, and how do we manage them in a different way that doesn't require making an appointment and coming in for an office visit. So that's a big subject. Another subject is around the cost of care and the understanding of what we do that may be wasteful or even harmful at times. So that's another area of healthcare interest nationally, and if you look at national numbers, we think about 25% of what we do as traditional healthcare may not have value or may be harmful. Now, what is value? Value is really two things. One, it's about longevity, and the second is about quality of life. It's avoiding complications, avoiding disease processes that lead to other things happening, and trying to manage in a way that we're delivering services that have that as our focus. And there are, services that are known in science that don't provide a lot of value, but they've been ingrained in our culture as physicians for years, and it's a really hard job to start these conversations about talking about those things and deciding that there may be some things that we don't need to do in a routine basis that could add resources to things that are more important. So that's another channel of work that I'm involved in, and teeing you up for questions. Hopefully you understand that. So, in a minute we'll get there. Another concept that I think is important to talk about is what is the role of a health system in social determinants. So social determinants, which the most important for our health and well-being are housing, transportation, food, and the environment of our children as they get educated and in the home, and avoiding adverse events in childhood. And when you look at that bucket of things in our life, improvements in those areas actually contribute about 80% to the value, meaning longevity and better quality of life. Only 20% is contributed by the direct patient care that we do as physicians and APs in the healthcare system. So an emerging conversation both here and in healthcare policy is what is the role of the health system around social determinants, and how should the front door of the health system be adjusted around things like housing and transportation and food, and that is front and center to how we're developing our population health strategy, which has a community and mission focus to it to help us understand, especially with the trust and other areas of the organization where we have opportunity to invest, how do we do that? And how do we pick things that make a difference, and how do we not pick too many things so we get diluted and don't make a good difference on any of them? So that's another theme. Operational efficiency is front and center for Concord Hospital, and we, as healthcare institutions, not just here but everywhere, it's a very difficult business to adjust toward more efficiency and more innovation in how we do what we do. And when you think of simple things, like, is it necessary for you to always come in and see your physician to get your meds refilled and do this and do that when you're perfectly well, things are stable? We could do an awful lot very simply that improves the ability for all of our patients to interact with us without a direct office visit. So e-visits, portal in the EMR, video visits, there's a lot on that list. So introducing innovation and efficiency in our care delivery processes is also front and center as how we design our health system as we go forward. And, again, teeing up for questions, what is it that you guys see that might be a service-oriented approach that you don't see today here? Looking at how we do work inside the institution, Tim Jones, our Chief Operating Officer, has been here about 4 years and has brought the concept of lean. And some may know a bit about that, and basically lean is a consistent way of managing operations in an organization that focuses on efficiency and process improvement and managing by data. Healthcare institutions tend to be siloed, so you've got the OR doing their thing, and you've got primary care doing their thing, and you've got a lot of that. And the concept of lean is to bring more consistency to the management processes as we look at how do we do business, how do we add new things, and how do we scale the best practices that we learn from this more widely in the organization. So we're about 4 years into that work here, and we're just at the point where we're extending that concept into the provider group and into the clinical management processes. And that's another piece that Tim and I are involved in quite a bit. Lastly, I'm going to throw out my last thought process is, where's Pam? I know she's in the back somewhere. We did an image survey recently, right? So we do that every year, and Pam tells me we've got over 20 years of data around how we are perceived in our community and our regions, and what's good and what's not so good. The one thing I want to focus on out of the image survey is our great reputation as a quality institution and as a stable anchor in the community. That comes out year after year. What we're not necessarily seen as is a leader in specialty services or more advanced technology or care. I think the image survey has pointed that out as an opportunity. If we're going to grow our system, what does it look like to add new tertiary level services, and how do we do that well, and how do we provide the access for that? Just building it isn't enough, but you have to be able to provide access. Examples of that recently for Concord are the level 2 trauma designation. So that's a new, very important care delivery process. In my world recently, the transcatheter aortic valve program was in that bucket, and there are robotic surgery and others. But what one of our jobs is to understand what is the value of those things and how do we integrate and build them. And one of the ways that we do that is developing what we call service line or value stream approaches to certain specialty services. So in my own area, it would include cardiac surgery, cardiology, vascular surgery, interventional radiology, instead of all being managed independently around their own group strategies, bringing that all together so you can plan how a service line meets the needs of our region, and also as part of that, how do you add new technology and new services. So I'm going to stop there. Hopefully that's enough red meat for you guys to ask some questions, and then I'd like to do some Q&A.
Well, I have a question.
Yeah, sure.
On the topic of access, if telemedicine was easy, I imagine a lot of organizations would have implemented it.
Right.
What are the challenges of implementing telemedicine?
So I'll go through a couple. The first challenge is around reimbursement. So telemedicine is beginning to be recognized as valuable as traditional face-to-face interactions in many ways. But the reimbursement for those interactions has not been consistent, and it's not consistent among the insurers and Medicare that pay for most of the care that most systems do. So as systems embark on this, there is a cost. We have to invest in technology, and also the people that are doing those visits are taking time out of their other work streams to add that access. So that's one, that's improving, and we're managing it. The second is it's a different work stream for most physicians and advanced practice providers. So how do you design an office workflow where a portion of your day is telemedicine or e-visits or video visits, and that requires a dedicated approach in a group of providers or a specialty to say, you know, we're going to carve out the responsibilities for people to do that work, and then on the back end, we have to provide an appropriate compensation and an appropriate release time for our physicians and APs that we ask to get involved in that work. So it seems like it's a simple thing, but it's an incredibly complex logistic to get things up and running. Most organizations start with things that are in the portal in the electronic medical records. So, for instance, one of our goals with Cerner is to allow self-scheduling this year, meaning in some ways, we'll start in primary care, you can go in and actually schedule your visit and get a date and a time without ever having to call the office or the transfer center. And that is really popular with patients, and then we can add in things like e-visits and video visits so that we can not only say, oh, if you're looking for a visit for a sinus problem, we can offer you a video interaction with this group today, right now, within 4 hours. And 90% of the time we could answer the question and have you treated without even coming in for the visit. So we're able to build out matrices around telehealth with that kind of a strategy, and here that's what we're already, planning to start with, is how do we use the portal. Patty?
With that same topic there, are there any government regulations with doing any
So,
of that?
so there are, and with telehealth, some of the things that are more developed are around specialty services like radiology and the like, where we may use groups that have physicians licensed in other states, and that's one of the barriers. In New Hampshire, it's easy if we're dealing with all licensed New Hampshire professionals, but if we were to deal with a broader group of people supporting us in these endeavors, we have to get every single one of them licensed and privileged in this hospital in order to allow them to do that work, even if we contract with a provider around video services. So that's one. And another is really around Medicare. Medicare does a variety of demonstration projects around care pathway improvement, but they're not well integrated with telemedicine concepts. So often they either create a barrier for you to do it, or they create no reimbursement for it. So those are some.
Okay, sorry, I'm gonna,
Yeah, it's all right.
I'm gonna join another one. With the telemedicine, as I'm thinking a lot in this audience, people here go down to Florida to winter,
Right.
which is a thing, and it just brings up the thought, if you're down there, could you, because your primary care is in New
Right.
Hampshire, let's just assume, could that be a future?
Right.
To be,
So I'll use an example from Carl, because we had the same thing. Illinois winters are maybe milder but no better. So we'll have people go to Florida and in Texas. And we looked at establishing small bases around areas where most of our patients and retirees went, where we could anchor a couple of practitioners to have the licensing and the EMR relationships and that type of thing established. And that worked out pretty well. And then those locuses can create relationships with a number of my patients had separate physicians in Florida, for their part when they were down there for 6 months. So then we can build the relationships with those providers in Florida that allows the information to come back into our system. There's other ways you can do this, and it depends on where the Concord Hospital and Concord folks tend to go, I find Naples is not unattractive, so
yeah.
we had a lot of ours in Naples. So, yes.
On the practical side, what will the patient need to be able to do telemedicine?
So one, important piece is the technology. So a lot of it right now is becoming smartphone based, so the smartphone is often the entry into the portal and the entry into video and e-services, and also an entry into education, so. But the difficulty we find in rural populations and Medicaid populations in particular is either they don't have the data set up on their smartphone, so they're getting a cheap plan and they don't have a data capability, so that's a barrier, or they may not have cell service access at all in a number of these rural areas. So we have to be cognizant with these approaches that we're meeting the full needs of everybody we take care of. And that's one of the tricks. And there are ways of managing that, but they're unique to each of the groups that you serve. Another need is you need to be an engaged patient, so you need to be able to go through, what would be teed up, but what's a thought process? Is it appropriate for an e-visit? Maybe a sinus infection, yes. Pneumonia, no. You have to be able to work through a set of questions and interact generally with the nurse about, and willingness to do that over a couple of minutes to kind of guide you to see whether it's appropriate or not. And then the third piece is we have to build not just for the patient, but for our physicians and advanced practice providers a comfort level that this novel access technology is meaningful, because we still have physicians that really don't want to participate in this type of stuff. So culturally, we have to start building that as a necessity. And there's others, but I'll stop there.
Thank you.
I'm gonna wait.
I'll change topics then. You know, I know you're trying to change providers to make more efficiencies, which could potentially change, you know, let's just say a physical visit coming in. And then the survey was mentioned. I would assume on the other end, as a patient, your expectations need to change too, because survey-wise, people, well, this used to happen and it's not, which might lead to lower, you know what I'm,
Yep.
you know what
Yep.
I'm suggesting
Yep.
here? And I don't know what my question is, but in the process of trying to change providers' minds, I think, is it being addressed for the expectations of
Yeah.
people as
And
well?
that's a really good point, because our traditional model, probably most of us in this room are familiar with, you have a need, you call your physician, you ask for an appointment. And in the new world, we're going to have different types of providers managing different types of things. So advanced practice providers are now a very important part of what we do. They may be the contact for you, either as a primary care provider or a partner with a specialist, and it's not the physician. So that's one expectation, both on the physician side and on the patient side, that you have to have a consistency about how you talk about team or team-based care. You know, the second issue is you need to develop a comfort level with patients that you're actually getting the things done that we say we're going to do. And we have a bit of a problem with this, with phone tag and no follow-up phone calls, no feedback comes. You know, it's a bit of a black box on the interface service side between patients and what we're doing in the system, so we need to correct that. And that's everybody. That's the system, that's the providers, and everything. And then I think, you know, creating an understanding of what an integrated delivery system is, which Concord is evolving to that, where we are becoming more integrated about how we coordinate care. One piece of that is dealing with nurse navigators. So nurse navigators in population health are often the patient's primary contact about non-acute problems and what advice they're getting. And so there's a number of builds that have to be done to create, you know, trust that this evolving new way of delivering care is actually meeting people's needs. And right now, we have physicians who are very nervous about moving away from a face-to-face transactional process. They're either worried about quality or about something dropping through the cracks. And some of us don't have trust that the rest of the system is actually going to do all those things we just talked about. On the patient side, we have a lot of patients that still aren't satisfied unless they directly see their physician for the answer. And we have to educate about that too.
I think a lot of it going forward too, and changes are hard for some people, but I know people that are younger than me that do not have access or don't feel comfortable to a computer.
Right.
And when they go into a doctor for a sinus infection, and it's found out that they have very, very high blood pressure. So then they start going, oh yes, I've had headaches. So all of this comes in, but on tele,
Right.
from the computer, can that be picked up? Could the high blood pressure then be something with a kidney failure
Right.
problem?
Right.
And so all of these things, and I'm thinking down the road too, because a lot of people, you're right, they want to have the doctor, they want that interaction, they want that comfort and that faith, and that to feel that they're a real person, that they're important. I'm thinking of liability down the road too. That puts a lot of pressure, or don't you feel it?
No, we do, and I think, you know, a lot of this is around system design, you know, so how do you design the filtering and the the process of understanding, is it safe for somebody to have an e-visit or a video visit? Usually the menu of things that are treated is pretty small, but they're frequent. They're upper respiratory infections, sinus, ear infections,
So many,
you know.
it broadens out so quickly.
Yeah, what's that now?
It broadens out.
It does, but it also is on the back end, you have a physician or an advanced practice provider who's managing that interaction. And we have to design that so that it has the safety net and the critical thinking as you would get it in the office. So that can be done. There's a lot of work done in this field about how to manage that. But it is new, and we do worry about things falling through the cracks. I would balance it by saying, if you're that patient who has those problems, we'll take hypertension, high headaches, and a sinus infection, and we can't even see you by any mechanism, you're going to end up in Convenient MD or some other place where you're going to get a 5-minute visit. None of that's going to get looked at. Your primary problem gets addressed, and you're told call your doctor for follow-up. So, you know, there is a negative to not offering better access services, because right now in primary care, we cannot see same-day visits virtually anywhere in our system. That has to change. So there's a lot to think about to be safe in doing this, but you make a very good point. Yes? Oh, sorry, I think you were first.
This is very informative. What do you see in the way of merger? Because I mean, obviously, we all know we have Boston,
Yeah.
and we have Lebanon,
Yeah.
two highly competitive, high-quality service areas for a whole slew of specialties.
Right.
So,
Yeah.
where do you? I mean, this is more kind of a macro, 30,000 foot
I hope so.
issue, but
I saw Pam stand up.
Yeah.
She's like, her ears picked up on this one.
well, I mean, I've got to believe it's hard to do that. So, I mean, do you know, for example, I mean, Dartmouth Hitchcock has a wonderful child development clinic.
Yep. Yeah.
I mean, are you going to try to compete with that, or
Right.
the cancer center, or
Right.
I mean, how does that? The pressure must be tremendous. And
So I'll take a high level stab at that, I think, and we'll confine it, to our region. But if you're an institution that offers a broad spectrum of services, like a number of our systems in New Hampshire, we need an adequate market to be able to do a good job with a number of those services. So we'll use child development as an example. New Hampshire has the second oldest population in the country next to Maine, and our birth rates are low, and our pediatric population is low versus the population. And so there isn't a need for 5 different child development programs. The difficulty with Dartmouth is theirs exists up in Lebanon, and that's not where the kids are. The kids are in Nashua and Manchester and Derry and all the rest of it. So that's one mismatch. Another mismatch is how do you reconcile what the traditional model of healthcare competition is, which has generally been we all want to do everything and we want to do it better and more aggressively than the partner in Manchester that does it. So you've got a number of services that are high tech and have a dedicated market that isn't growing very much, and you have several hospital systems all trying to compete and put capital into those areas to try to own the market. In a way, Dartmouth came right out and said that with what they said about the CMC merger, is they believe they're preferred as an academic institution in New Hampshire, and they ought to have special treatment to capture the market that is now owned by other people. So the state will have to reconcile that conversation. I think for us, we have to decide in the markets that we serve, which is central New Hampshire and up into the Lakes region, what are the needs of that community and what is it that we should do that makes the most difference. And there are perhaps things we might like to do that we would decide not to do because they're either done well by somebody else or our market really doesn't support the investment we might make in those services. That's a very high-level, complex, set of things to think about. I think what's going on in New Hampshire right now, to put it very basically, is health systems are anchoring their market because they want to be better or first or more capable than competing health systems, and that's Dartmouth CMC, and that's partners in the Seacoast. And I think we have an opportunity to be more mission focused about our community and our region and how we identify what we want to do rather than a revenue-based discussion, which almost all of these institutions, one of their main focuses is growing revenue, for the institution. So I think Bob and I talk a lot about this. I think we have a great strategy and a great opportunity. So.
I grew up in Illinois, and my father was a patient at the Carl Clinic, and he had excellent care.
Well, good. I'm like, uh-oh.
But it had a really good reputation. I'm questioning, how have these kinds of issues surfaced at the Carl Clinic? And how are they dealing with some of these issues that seem to be pretty national?
So that's a great question, and I think these are not unique to just Concord. This is a national discussion. One approach, which Carl did many years ago, is we own a provider-sponsored health plan. So it's called Health Alliance Medical Plans, and it was sponsored by the physician group prior to us integrating as a system, because the belief is that we're able to put more of the premium dollar toward care delivery than a for-profit like an Anthem or a United Health. Typically, provider-sponsored health plans deliver 91–92% of their revenue toward the clinical space, where it's only in the low 80s for most publicly traded large managed care organizations. So it's one about how do you manage the flow of revenue and allocate it appropriately. So that's one strategy. That helped us with population health strategies, which when you look at, I'm going to get a little in the weeds here, but we'll use an example. So COPD, breathing problems, are something we're developing a care pathway for population health around, which what are the goals? The goals are to keep you more well, keep you out of the hospital, and have a better quality of life. What that produces for the health system is fewer admissions for that population and fewer uses of other services other than the ones that are targeted to accomplish that, and less waste. So you as a patient, it's a much better way of managing a chronic disease. We as a health system lose money in the traditional fee-for-service environment. So being able to manage your revenue around approaches to revenue that are directed toward those types of programs rather than one action, one reimbursement, what we call traditional fee-for-service, has to go in parallel to us developing the strategies, and that's another thing we worked quite a bit on at Carl. We had to put numbers to it. About 30% of our revenue was in pure capitation and another 20% in some variant of risk contracting. So we're just starting that at Concord, and I think Bob is, one of the reasons I came here is I like the way Bob thinks, because he believes that's the future, and I believe that's the future too. It has to be. So it's pace that's important. So those are just two things to think about.
Anything that surprised you about our system or our area that you didn't expect?
I would say not a surprise, but certainly something to work on, in that we have been through a challenging couple of years with implementing Cerner, developing a system way of thinking, all the things we're talking about, and the engagement of our physicians is low, meaning the trust in what we're doing is not as good as we would like it to be. The understanding of what we're doing needs work, and having champions in our physician group who want to work in these ways is a work in progress. So, we measure that on an engagement survey every year, so we get a number for it, and, so I've seen that before I got here. I knew we had work to do. But doing all the meet and greets that I'm doing, what I'm finding is we're in a bit of a rut. We're you know, I don't know, I'll get macro again, but when you do disruptive change, you get worse for some period of time before you get better. And we're kind of stuck in that valley in some ways right now in the physician group. So I see that as a very important thing to focus on, and how I focus on it is communication, opportunity for engagement and participation, in education about what's different from how it looked 5 years ago to how we think it's going to look in the next 5 to 10 years. So I've spent an awful lot of my early time being out and about in town halls and meetings and conversations to try to figure that out. Yes?
With your vision for telemedicine, to be successful at that, is it typically everybody's got to be all in for the medical staff, or do you select, okay, these 3 providers at practice A are going to use telemedicine and the rest are not going to?
So it's usually incremental, and I'll tell you the spaces that I think it has the most value are around low acuity primary care access. So we would say we would have some sort of centralized process. To go back to Patty's question, that depends on the patient being willing to see a telemedicine provider, let's say in Pembroke, rather than their primary care physician in Hopkinton. So, but the loop is closed on the back end so that everything gets back to your primary care doc. So we would create a locus, as an initial strategy, and some systems partner with, a service provider like American Well or something that has these things pre-built and figured out. Let's see. Another piece of this, honestly, is behavioral health, and this is a real, you all know this issue in our state and our community, and a lot of that difficulty exists in more rural environments, where the ER is really the only option. But building out an integrated behavioral health model in primary care that allows social workers and behavioral health APs to manage lower intensity stuff like general anxiety and lower level depression, which is really the bulk of the primary care work, can have a telemedicine strategy associated with the follow-ups that's been shown to be valuable. So that's another thing that we're looking at. Yes.
So you talked about the challenges of, excuse me, my voice is gone, physician engagement and that being a little bit of a surprise to you. Is there a bright spot or something that surprised you coming into the community here or the health system itself that was on a positive note?
Oh yeah, there's a lot, but I'll share one, and that is despite the engagement, the willingness and the culture here of everybody to talk to each other and be, they may not be happy with what's going on, but the conversations exist. And I see that in our meetings. We do a lot of meetings at 7 a.m. and 5 p.m. with the physicians because that's when we're free. And often it's a struggle to get people to come at those times. Here, every meeting is almost attended by everybody who's supposed to be there all the time. That is really unique and positive. So the interest in understanding what's going on and how do we participate is ripe for the picking, as I would say. And then the other thing is the interpersonal culture here is fantastic. Just just walking around, it's warm, people talk to each other, it's palpable. And I told Bob that when I interviewed, and I think Patty, he agrees with that, and everyone else I've talked to has said, yeah, that's one of the secret sauces we have. So one of our tricks is, as we grow and change these things, how do we not lose, touch with that great culture? There was another question here, yeah.
I was wondering about the social determinants of health that you had mentioned, and as you think about our system becoming more engaged on that front, are there opportunities that have stuck out to you where you could imagine doing quite a lot more?
Yeah. some you probably are interested in. But, yeah. I'll use examples from elsewhere first, just to kind of point the value, but Geisinger is something I often point to, and they looked at their diabetic, low-income population, and one of the stressors of managing diabetes is food access, proper food access, that type of thing. And they created a food bank where your benefit by being in their health plan was access to education and the food bank in order to manage your dietary needs, not just with this is what you should eat, but oh, by the way, we're going to provide you access to what you should eat at a very low cost. Here, I think we have opportunity, as you know, in elder care, and we have an aging community. Many of our patients are aging in place with limited resources, and the ability to manage chronic disease in the home environment is a real opportunity, I think, in our particular community and the region that we serve. And as we're evolving our population health strategy, we're looking at a concept called an age-friendly health system and an age-friendly community, and we're developing partnerships with the state and other health systems around those thoughts. And to get granular, it's around home support. The VNA plays an important role with us in this. Food support, social isolation, and transportation. These are all things that we in the health system can think novelly about how do we do a better job. And honestly, if we do well with that, we probably lower cost of care and lower waste, because people aren't coming in urgently when they need services as much. Bam.
Just to follow up that point, so we have in the Family Health Center a frail elder program, which is home visiting.
Right.
Have you ever thought about and I know it's too soon, you've only been here 3 months, but the opportunity to expand that in terms of our primary care practices to bigger than just the population for Family Health Center service?
Yes. I'll go a couple pieces to that, which I'll add one on, which is as we look at transitions of care for older folks, so let's say coming out of the hospital back into an outpatient environment, we have a variety of mechanisms. We have rehab, we have short-term facilities, we have long-term facilities, we have social work, you know the menu of stuff. We don't apply those evenly and consistently throughout the whole system. So we have a program in the Family Health Center, we have other programs in elder care, they're very almost trial basis type things where we haven't taken the next step of saying, this is really important for the whole system and we need to invest in this, consistently no matter what your payer status is. So I see that as one of the next steps for us, especially around elder care, is, make it a system strategy, not a project strategy. There's a lot in that space to talk about. I'll get to you, but I wanted to throw out an example of a good thing a managed care company, United Health, is doing. So United Health has just embarked on a program of providing housing in 30 different cities for their beneficiaries that are low income, and in these housing locuses providing primary care medical services and linkages to help with other social determinants. And they're going to spend $700 million over the next 5 years developing this in 30 communities. They did their pilot in Phoenix, and they have both an improvement plan around quality of life and care, but also they believe they're going to have a 3 to 5% return on investment for that by lowering cost of care with these chronic, lower income populations. So it's a fascinating thing to read about. You can Google it and read about it. A guy named Jeff Brenner that I know from Dartmouth is the guy now employed by United. He's a physician who's actually in charge of this program. You had a question?
What's your thoughts on our trust and our mission?
What's that?
I did not plan to.
Okay, being a pilot for a few years, you have to talk a little.
What's your thoughts on our trust?
The trust and the mission of the trust. So, a couple things about that. It is incredibly important for a robust system to have a robust trust. So I, in my prior life, spent a lot of work with our trust, our foundation, around the meaningfulness of that. I think it offers an opportunity both for people and financially to help us invest in some of the things that we're talking about, define what that should look like. And I'll add another layer to it. I think it's really important that we bring our physicians in particular into contact with the trust and develop a group of champions. We have a couple. Ron Yap, I know, is very involved. He's a great guy. But we need, many more that are interested not only in financially contributing, but contributing time and interest and, opportunity that gives us ideas. So one of the things I believe I need to do is help that development inside our physician group vis-a-vis the trust. The mission of the trust itself, I know what is written, but I think to me, it's a living thing. It's something you talk about all the time. So I believe it has a great opportunity around social determinants and thinking around that, but it also has opportunity around how does our healthcare institution evolve in the types of care we deliver. Not necessarily the next new robot, but perhaps some of these other things we've been talking about care delivery processes and how do we invest in that. Rusty's like, what do you mean not the next robot? See if I missed anything here. All right, I'll tee up one more thing, and that is we as physicians in particular need to be better educated as healthcare leaders. Healthcare leading has been predominantly a job of non-physicians over most of my career, and it's only a recent phenomenon that we're developing an integrated model where physicians are entering jobs like mine, where your responsibilities are predominantly around strategy and tactics and not necessarily the ground floor patient care. So we're not positioned well as a physician workforce in the United States to, answer that charge. So we need to have mechanisms of leadership education and interest and also both incentive and release time from the health system to be involved in those activities. In my own world, I did a lot of, bootstrap education as I went through leadership at Carle. But I went back a couple of years ago to Dartmouth and did the Master of Healthcare Delivery Science degree, which is an integrated program with Tuck and the Dartmouth Institute, which is really around policy and sort of anchoring your knowledge base and networking, very important too. So I think leadership development for the providers is really, really important, and we're going to be spending quite a bit of time this year on getting that developed. Am I overtime, Pam? Or? Okay. Okay.
Thank you, Dr. Gibb.
You're welcome. Yeah, great to be here. I should say I haven't met all you individually, but call me, or if you have questions, come by and see me. So I'd love that. Okay.
And if you have a golden retriever, he can maybe look.
Yeah, right. No, more importantly, if you know a good pet sitter.
I'm the only cat lover in the room, Carl.
Yeah, we have 4 cats.
Yeah, I am too.
Thank you, everyone. We look forward to seeing